Nisa, you can try sharing. It's visible, sir.
That was visible, na? You can put back your the logo slide. No issues.
Thank you, sir.
Good evening, Supreet sir.
Hi, good evening.
Sir, Tarni sir has already joined. Can we start?
Yeah,
तो please
let me.
शुरू करता है.
Sir, I'll just call Dr. Satyajit once and then we'll start.
Yeah.
Just
Yeah,
give me a
yeah.
moment.
Call and we start. Yeah.
Yeah.
Sir, Dr. Satyajit is already with us. Sir has joined.
Yeah, he has joined, and Dr. Akhil, you called him?
Yes, sir. Our team has contacted Dr. Sir.
Yes. So Dr. Akhil will be joining in about 2 minutes. Let's start meanwhile.
Okay, sir.
Hello, Supreet.
Hello, sir.
Hi.
Good evening, Tarini sir.
Hi, good evening, Supreet. Good evening, Satyajit.
Good evening, dear all. It gives me pleasure to invite you all to this important webinar on one of the not so commonly discussed topics in non-small cell lung cancer. We thought of this topic because often in the popular discourse, we see discussions happening on EGFR, ALK, and ROS, but unfortunately, we don't see too many sessions or CMEs happening on uncommon targetable genetic alterations in non-small cell lung cancer. But on the flip side, we need to know that we should be aware as medical oncologists regarding these genetic alterations as well, simply because of the fact that lung cancer is the second most common cancer in the world with ever increasing incidence both in India and worldwide, and also because of increasing access to various molecular testing methods to our patients. And today, next generation sequencing, if it is a limited panel, it might cost around 7,000 to 10,000 rupees. If it is a broad panel, it might cost around 30 to 35,000 rupees. And we find our patients not hesitating anymore to undergo these tests. So with increasing access to NGS, we will be coming across more and more number of patients with these uncommon genetic alterations, and we should be aware of which alteration is targetable, which is not, and how to go about testing, diagnosing these alterations, and then proceeding with the treatment. So these are precisely the learning objectives of today's session. Firstly, we'll try to understand how to diagnose these uncommon genetic alterations, which will be delivered by Dr. Tarini Prasad Sahu, who is a consultant and a director in Silverline Hospital, Bhopal. It is always a pleasure to listen to TP Sahu sir. I have listened to him personally in various platforms, and I really found a lot of knowledgeable interactions with him, and it was always fun to speak to him. And we have Dr. Satyajit Pawar, who will be speaking on ROS1, NTRK, and KRAS alterations. I know him very dearly. We go back a long way from my days in Dinanath Mangeshkar Hospital. He has been my mentor, my inspiration towards excellence in academic oncology, and I always try to be like him. Then we have Dr. Akhil Santosh, who is a young and dynamic medical oncologist who is very active on various social media platforms, and we find him engaging in various academically enriching interactions. So with these people guiding us, navigating us through the discussion today, we'll start with our first speaker, TP Sahu sir. Over to you, sir.
Thank you, Supreet. So this was a few weeks back when I got a invitation to be part of this meeting uh, from one of the most active persons in the medical oncology WhatsApp group, and that's Supreet. So I just could not refuse. Although this was technically very demanding, the topic is beyond what we normally do as clinicians. It was more of the lab and pre-analytical. So, Supreet, thank you first. Ideally, I'm not expert. That's my disclaimer on this, what is going to see. I may speak something which I would not have full knowledge on. That's one more disclaimer, and I would love to be corrected because this is not my area of expertise. But yes, as Medonc, we are expected to know this. And this is something that I really acknowledge, and such opportunities really give me a little more knowledge about how to interpret NGS. Although I've done it pretty many times, I've done this lecture, but every time I read, I learn more. And this is something, and I always feel we still don't know so much as Medoncs, although we write NGS report to be done every day nearly in our OPD nowadays. So that is something. Thank you, Supreet, for that. So what I'll be doing is I'll be just doing the groundwork for my two subsequent speakers who will be doing and take really doing taking the icing on the cake to do the treatment part of it. How do I treat those cancers, which is normally what we do. So let's see how it goes in the next 15-20 minutes, which is the time given to me. I'll try to make the best of this.
Sir, it's okay to relax with our typing, even if it is 5 or 10 minutes
No,
more.
I would not and cannot speak more than that
Okay,
because
sir.
it is a topic which you understand. So I
And also,
understand what you're saying. Yeah.
and also for all the participants, we will be having Q&A sessions after each speaker's talk, and you can always ping in with your messages in the chat box. Thank you, sir.
And Satish so happy that okay, this talk
Yeah, I
has
will
gone to
use
Dr. Sahu.
I will use that time then.
Okay, so now let's go down to lung cancer and how we normally do a non-small cell lung cancer, especially advanced, is all of us take a tissue biopsy and we want to send it for a next generation sequencing or do some IHCs of fish, whatever modality we want to, and mix and match those. This is what is normally done. This is a 2023-24 guidelines which you have taken from the ESMO, which is the modification of ESMO. The SCAT, if you look at this, is a ESMO. The grade 1 is what they have put the really required thing which nearly should be done where you have effective treatments, and the grade 2 is something that has evidence but that is evolving, and grade 3 is like that, the lesser evidence. So this is the ESMO level of grade recommendations for targeted therapy for molecules that we find or mutation that we find on NGS. So as we know for lung cancers, and if you look at the NCCN guidelines for the past few years, you would find that ALK, BRAF, EGFR, MET, NTRK, RET, and ROS and the common EGFR mutation, which I'm speaking of, has been the mandatory, what we minimum used to do because there were effective treatment at that point of time. The recommended SCAT2 is something that is probably now nearly mandated, and we are doing it, the MET, KRAS, HER2, EGFR. So I'll stop here for these two, SCAT1 and 2. And if you look at it, most common and few of these recommended minimum criteria mutations which we should look at, all of them are not very common. And look, if you look at the percentage of it, EGFR constitutes approximately 1/3 of the whole load of lung cancer mutation. You would find the KRAS, probably also the G12C, to be quite a common. But if you look at the KRAS as such, you can find many more KRAS mutations which can come as a co-mutation or single mutations. But the G12C is important because we have a molecule that is specially approved for this specific mutation. So this is around 6 to 7%. This could vary cross registry. I'm talking of the commonness. The ALK is the third most, which could be, or MET put together is under 5-6%. But the rarer one is ROS1, the RET, the NTRK is one of the least common, but we have 2 or 3 drugs now at least that have been approved, and one of them is still available in India. So my point which I wanted to make here is, if you look at and do why we need to do these mutations, because these mutations have affected the way we treat patients. And why are we doing mutations? Because we now have effective drugs that are enhancing the responses and the quality of life and the survival of the patients. One more mutation which is not there because we do not have any targeted therapy, but one of the most common co-mutation which we do find when we have NGS is the TP53. And this mutation, we still are in a struggle. We all know that it is bad. But how do we tackle this badness in the co-mutation if there's a TP53? None of us know. We have different ideas. Like if I have a EGFR, let's say 19 or 19 or 21, and there's a TP53, we have a lot of things that do a combination of chemo plus a TKI. All of us have different ideas, but we don't have level 1 evidence for this sort of combination that it is better or something else is better till we get a drug that is targeting TP53, and that is in trials. We don't know when it will come into practice. So this is why we are doing these tests. We may use different technologies like NGS, which is most commonly used. I'll come to that in a minute why we are using that. We may use a PCR, we may use a FISH, but which is the best way to utilize your tissue is something that's important, especially for lung cancer, which is not a breast cancer, which you have large number of tissues. Here, most of the tissues are CT guided or transbronchial, where tissues are limited and you want to optimally utilize it. So let's move forward. Why have we moved from Sangers? Because Sangers is something when I was a DM student, at least a decade back or 1.5 decade back, we used to depend on Sangers for all our mutations. So why Sangers and why do we need NGS? Why not Sangers is very clearly written here. Although both are looking at the genetic part of it, the cost effectiveness is very low for a Sangers because it's very time consuming. The report used to come at 3 to 4 weeks. And if you look at the application, it is ideally for sequencing single gene, where in NGS, it is more rapid sequencing. You can scale up the things and have the cost efficiency better. And you can have also the whole exome genome sequencing in NGS. You can also have a targeted sequencing, which we are knowing it as hotspot NGS. That's what you can do in NGS. If you look at it, the data output for NGS is large, but there's a limited data output for Sangers. The clinical utility for Sangers is nearly lost, except for in research setting. Now, in clinical setting, none of us, last time when I did a Sangers, I don't remember. All of us shifted towards NGS, and that we will come to in a minute. Why? Before going in forward, this is probably the take home what people should know. It's better to have a RNA and DNA based NGS. I think that all of us know why and what. I'll come to that in a minute. If you're doing an NGS, make sure you write for RNA and DNA both, because you are going to miss out on fusions if you just do a DNA. That's something that people remember. Number two, which I will elaborate when I go forward, is NGS limited panel at baseline is okay. Maybe okay. Can we and should we do just a hotspot? That I will just discuss in a minute and I will conclude when I conclude. But once on progression, if you want to know the mutational pathway, you may not have drugs, but you might get a hint of what's happening. You may probably need a much more broader panel at progression. But there is a controversy to the statement. If I speak to my contemporaries, colleagues, and if you look through literature, people have also recommended a decent amount of the genes to be tested at baseline, not the 8 gene only, because the other genes also which are there could affect the treatment which you are going to do. Let's say for immunotherapy, there are few mutations which you would not or be not be very conveniently using immunotherapy for a patient who has difficulty in arranging finances. Let's say KEEP or STK. If there is there, conceptually you would have a resistance or relatively low responses. If I have deep pockets, I will still use it. If I have a very limited pocket, someone who is maybe getting money at a big cost for his treatment, I'm a little skeptical, but level 1 evidence still doesn't prevent me. So my point here is, at baseline, should I do a hotspot panel or should I do a relatively moderate panel of 30, 35 genes or something at least, which covers nearly those so-called lesser evidence, which really targets, modulates and pushes me to a right treatment? I'm not sure. But someone wants to do a hotspot panel is fine, but at least do a broader panel on progression is something which I want to carry the message forward to the people who are listening to this. So when I look at NGS, the problem where what happens is when we, as medoncs, when I was trained, at least NGS was not that common. We just used to have the IHC and the PCRs and the FISH. We did not have NGS, but it just came up when we passed our DM and just went into practice, and gradually it has evolved. So what is NGS is something people remember. You collect a blood or a tissue, and then the DNA or RNA is extracted. And when the extraction is done from that patient, and then they are fragmented into multiple fragments of 300 to 500 base pairs. And the extracted fragments is then sequenced. And then there is end repair and adaptive ligation, which happens. And after that, what happens is the segment on interest is amplified, and the fragments are then there is a quality control which needs to be passed. And this is where I'll spend a little bit of time. What is the minimum QC you should look at? Because people, most of us, even medoncs today, when we look at NGS reports, we just look at the green and the red label which comes. Green, no mutation. Red, then we want to go into what mutation is there. We rarely spend time on what genes has been covered. Is it a hotspot or is it a comprehensive panel? what is the depth, how many reads were there, what is the coverage, and what is a VAP. And if there is a co-mutation, how do we look into which is the prominent mutation which I should target first? So these are something which I will try to cover in the next 10 to 15 minutes, and let's see what comes out of it. Okay. So now let's come to the reads versus depth and coverage. This is something as medoncs, I think all of us should know if I am writing even a single NGS to my patient. The reads are the total number of sequencing fragments that are generated by the process of NGS, which I spoke just a slide before, that this is the reads usually is in millions. So it's the number of sequencing fragments which is generated. The depth is the number of reads that cover a particular base. I will come to a very simple example, probably that will help people who are into this now to understand more. So what is the depth? You want the number of reads you are reading a particular nucleotide or a sequence of nucleotides. That is what a read is. So more the reads, more is the depth, and that is more confident you are about the report. Coverage. What is the percentage of the target region that is sequence of the total genomic sequence? So basically, you want to cover as much gene of that gene as possible so that you are not missing out on any targetable mutation, which may be present. Because if your coverage is, let's say, 10% of the total possible genomic sequence, then it's very likely that if there's a target in the rest 90%, you will miss it. So what is reads is the quantity what is generated. Depth, the more it is, the more confidence it is that this is something that is not a false positive. You are sure of the report. The coverage is the completeness that you have tried to cover most of the genomic material, the sequence, so that you are not missing any particular mutation. So this is what it is. I very clearly told what it is. The example, reads are usually in millions, that is 10 to 20 millions. If you look at the coverage, normally the coverage is around 95 to 99%. If you get something below that, you should be not confident of it. The depth, I will come to that. It may be 100x, it may be 500x, or it may be thousands also. For rare mutations, which are very, very rare, you might need a depth of beyond 500 to 1000x. For germline mutations, your depth may be 30x or 50x also would be good enough, because that's a germline mutation. I hope that point is getting forward. To get it more simpler, and this is chat GPT generated. When I was going through, I use a lot of it in my to understand things, and this is something which I felt will give a very important part of it. So what is the read count? So I've taken some photographs. I'm photographing a book. So I've photographed many photographs. So how many photographs I've taken for the particular book, let's say the Davidson, which we want to read, is the read count. So that is my base. I've taken, let's say, 1,000 photographs of Davidson. Coverage is how many pages you captured of that particular page which you want to have. Let's say I wanted to read about pneumonia, and how many of these pages had pneumonia in it. So that is so how many of the I'm sorry here. So the coverage is something that the book has 1,000 pages. So how many pages did I take the photographs? Let's say 900. So I'm nearly taking 900 of the 1,000 pages which are there in the book. Depth is how many of these pages have pneumonia as a word in that photograph. Is that depth? So I hope I made it pretty easy for it. So depth is how many times I've read the sequence of nucleotides or the nucleotide in terms of NGS what we read. The coverage is what amount of the genetic material which you want to see has been covered by the technique. And the read counts is how many genetic materials copies have you produced. So these three are very, very important, and I've tried to simplify as much as possible. Let's move forward. So with that, I will just go down to tell you how much of these are important and what we should be looking at. If you look at it, we should be having, if it is a tissue, we should be having a depth of 500x, but minimum of 100. But if it is more than 500, I'm pretty happy that my false positive of my read of that mutation is very, very low. The number two is coverage. And as I told you, it should be a covering at least 95%. You can go up to 99% which will be there in liquid biopsies, but in tissue biopsies is around 95%. The read count, as I told you, usually is millions. 10 millions is a good read count. If you look at the rare mutations, which is the focus of this topic today, your depth suddenly increases. To be more confident not to get a false positive is around 800 to 1000x. And this is something people have to go back and start minimum 500. Don't take for a rare mutation, and if the depth is 50, for germline it's fine, but not for pathogenic mutations. If it's a rare mutation like NTRK, your depth of 50 to 100 is not sufficient. You have not read that enough time, that the nucleotide is not seen that amount of time to be pretty sure of what the report is. The coverage for rare mutations is again going up from 95 to 98%, because you want more tissues to be covered so that you do not miss out on the rarity of the mutation, because it's very, very rare. And your read count also correspondingly increases. But for ctDNA, if you look at it, your number of depth you see can go up to 10,000 also, ideally. And the coverage goes up to 99. And the read count again goes up correspondingly to 20 million or more. And why that in liquid biopsy? This is important because if you look at the liquid biopsy part of it, you get the ctDNA, which is a very small percentage of the cell-free DNA. So your chances of getting the genetic material is so less. So this is why this coverage is so important. The depth is so important. That is why it increases. So now we move forward. What is a hotspot and what is a whole panel NGS is something we need to remember when we are looking at NGS report. The whole exon sequencing or the whole genome sequencing, if you look at the number of base pair sequenced, it is as big as 30 million. The number of gene sequence could be as big as 22,000. And you could capture any mutation which you are not targeting, any new thing that could have not have a clinical significance today, but we might have after a few years. But if you have a panel testing, which is very specific, if the depth is adequate, and if that depth is okay beyond 500x, you are pretty sure for that 8 panel that are there, you will not miss anything. But you will miss rare mutations which are not there in the panel. So that is something people remember. So for a hotspot which we are given in coupons, be careful to see the depth and of the panel, which we should be pushing for at least 500 to 1000x. If it is not there, and if the depth is only 100, please do not do that hotspot NGS, because although the panel is limited, still, because most of the mutation lung cancer are rare, less than 1% or 1.5%, you will not get adequate reports, and those reports may be falsely, and the patient does it with a good, let's say, lab outside India. You might find that the reports would have picked up a rare mutation, which the normal hotspot panel would not have picked up. So this is probably the thing which I wanted to tell. Hotspot is not bad, but you do not expect anything beyond that. But even in the hotspot, make sure the depth is deep enough so that you do not get false positive or false negative reports, and they are bare minimum. So now come to the second part of it. What could be the challenges, which was given to me very specific? What could the pre-analytic challenge? And that is something we have to make sure. First thing, what should be the age of the paraffin block? Please try to use anything within 2 years. Earlier the better. And this is given in multiple guidelines, but there is a ISMPO guideline which was published few months back for NGS reporting. And that guidelines also mentions do not try to use blocks which are old and especially beyond 2 years. So this is point one. That is why if you see prostate cancers for patients who relapse usually after many years, people are recommending NGS to be done at the baseline. Because by the time they progress, 50% would have been after 5-7 years. The hormone sensitive becomes hormone refractory. And you would not have the tissue good enough to do NGS on that. You need a new tissue. And most of the prostate cancer patients are bone mets only. And the tissue quality from bone is very poor. So this is important, is the time of the paraffin block. What is the formalin that is used? And I'm pretty sure, including me, I'm guilty to that. We don't get back to the histopath report. If you look at the molecular pathologists, their recommendation is 10% formalin is what they want. That gives the best fixation. And above that is bad, because it degrades the quality of the genetic material. So very important is the time period, the material which is used for fixation, these two. Number three, let's look at the tumor content. We have to ask a pathologist, please specify in a small biopsy specimen what is the content of the tumor and what is the necrotic area. People also tell 10% is good, but if you look at the recommendation, the molecular pathologists are confident with 20%. So if it is 20% tumor tissue in the paraffin block, that is what they want. And this will give a good chances that your NGS reports will not fail. Number three, which again is something which we are not taught many times, is the nucleic acid yield. That should be written by the NGS person, which normally we do not look. And if you look at the guidelines, in lung cancer, more than 30 nanograms of nuclear material is good, but 100 nanograms would be optimal. So that is something we need to push our NGS guys. Please write what is the amount of genetic material you could extract. And last, what we can initially tell in the pre-analytic, which maybe things why they fail, is the fragment size. Because as I told you, these are split into small fragments and then they are augmented. The fragment size is usually 300 to 500 base pairs. If these amount of fragments cannot be done, the tissues are so poor quality that if the 100 base pairs, 50 base pairs is only taken up as a fragment, then your chances of getting a false negative will be very high. Your quality QC is not passed. I hope this part is pretty clear in the layman terms as we medoncs can understand. Now come to the liquid biopsy pre-analytical. I told of the solid biopsy. ctDNA accounts to 0.1 to 10%. So what they look at is if the cell-free DNA cut content, the ctDNA is around 10%, it is pretty good. But many times you would not get the ctDNA to be 10% of the cfDNA. It's only possible when the tumor load is very high. Normally, the ctDNA component is approximately 0.1 to 1%. But the more it is beyond to touching 10%, the chances of failing the QC will be very low. But the most important for liquid biopsy, time is an essential factor in liquid biopsy. If you are sending somewhere and the sample is not sent at the right temperature, right time, and if it reaches to a lab after 2 days, let it be the best lab in the world, the chances of failing on a liquid biopsy will be more. That is why you look at it, Guardant and everyone has set up labs in Singapore and in other places in Asia, because transporting the samples to US many times is a logistic nightmare for liquid biopsies. Many of us question why are we doing it locally, but the answer is for liquid biopsy, if you do it to a transport time which is in 20 to 24 hours, it is very, very poor. The chances of failing will be high. They want a time period of 6 hours, 10 hours, 12 hours. This is what they want for the good quality and the QCs to be passed on liquid biopsy. This is something we as medoncs have to remember when we are doing liquid biopsies for NGS. And third, we have to see on the liquid biopsy NGS that the flow cytometry and other methods have been used to specify the sample percentage of the neoplastic cell. I think this is something that we need to be looking at when next time we see a NGS report on a liquid biopsy. The last part is something which I've already spoken, so I will just move over to the next slide. This is something that was new to me. I don't know whether Supreet or others, Satyajit, or anyone was aware of it. But next time, ask your NGS guys to give you the Q score. And the minimum Q score is 30. What's a Q score? It's a Federate pH red quality score. It is a quality indicator used for by sequencing, by synthesis of the NGS chemistry. The matrix is a reflection of how accurately are you identifying a base on a particular platform. Because NGS is all about base recognition. So the calculation is given. I'm not expert on that, but what I take back home is if a Q score is at least 30, that is best. So next time you see NGS report, look for the Q score or ask your person who's giving you the NGS report, show me where the Q score is, because the probability of a wrong base call is 1 in 1,000 and the accuracy of a base call is 99.9% because you can never be 100%. So that is why Q score of 30 is the ideal. We may not understand the chemistry, how they calculate, but the Q score of let's say 10, I'll be not sure that the base that has been identified by the depth is accurately be identified as adenine or guanine. I hope this part is also clear. So this is again something which is new, which I read when I looked at this slide and prepared for this talk. And this is how you actually learn and improve yourself over the time. The last part of it is VAP, the variant allele frequency or the fraction. This all of us look at it. What people tell is if it's a known mutation, let's say EGFR exon 19 or 21. I know the sequence of mutation. 3% is good enough. Even 1% is good enough for a patient with a lung cancer. But if it is something that is not known, don't know what the frequency or the percentage should be, we are looking at anything 5 to 10% or more to be clinically relevant. Whether we have a drug or not is something very different. But VAP of above 50 should raise a suspicion of germline mutations. But otherwise, the somatic VAP cannot be 50. So this is something again people remember. How I use VAP, if there are 2 co-mutations or 3, I try to target the higher VAP. And especially for a VAP, for the mutation which is known pathogenic. So that is how VAP guides me in my practice. Okay. So very quickly, please also look at it. What method are they using in the NGS, the Amplicon or the hybridization capture method? I won't go into technicalities of it, just to tell you that if you look at the Amplicon based, it's a multiplex PCR where what happens is by the Amplicon method, you just do the targets are enriched by the PCR amplification by multiple multiplex reactions. But with the hybridization capture, what you do is you first get the DNA fragmented, and afterwards the targets are selectively captured. After the adapter and ligation done, they are captured by a particular probe which nearly look at it, and then the final library is done. So basically, after you have fragmented, the adapter and ligation is there for both the technique, which is required for, at least for the recognition. Then here you put a probe tool for what you actually need. And once the probe tool attaches to a particular sequence, then that library is done. And here you multiply by the PCR, then the adapter ligase is done, and there is a much more library which is there in the Amplicon rather than the hybridization capture. But what is the basic difference? Amplicon is good for small panels. If you want to do larger panels, the technique that is normally used is hybridization capture. This is again something which we can and should read in NGS. What was the technique they used? Because these are the 2 most common technique. There are some 3rd generation techniques that people are using, which I am also not very clear about it. But these are the 2 techniques which have been used till recently and people are still using it. Hybridization technique, more comprehensive, more costly, longer hands-on time. Amplicon is more affordable, cheaper, easier workflow. So what I mean to say by this is I just don't go by cost. You might be doing Amplicon for a 500 gene panel, which might not be the best way to look at it. If I look at a 500, 100, 150, 200 gene panel NGS, I'd be more happy with if I'm doing a hybridization capture, because that is the technique which you would be looking at predominantly for larger gene content. I hope this is again clear on how I look at the NGS. So now I'll come to the last slide of mine. Take home for me, molecular alteration is important to detect. We have already, as Medonks know that. Interpretation of NGS is paramount. Just writing NGS and just writing a drug for that mutation is not sufficient. Your target should be, your false positive reports of the NGS should be as low as possible. And your chances of false negative should be also as low as possible. Because you are going to target that drug patient probably without chemotherapy. So you want to be pretty sure how it is. QCs are vital. As I told you, for rare mutation, for that topic today, at least look for anything beyond 500, but be comfortable about 1000x. See that 95% of the coverage is there for solid biopsies, and for liquid, 99% of coverage is there. The reads are at least 10 millions to 20 millions, depending upon which samples you use. Amplicon and hybridization is something you need to look at. Smaller panels is okay, but larger hybridization is a technique which you want to use. Look for the Q30. the Q score which I told, which is the perfectness by which the person is able to detect the base, and that should be and minimum 30. This is something again which we need to read. Detection of rare mutations, which the next two speakers will tell us how we need to intervene, are important for prolonging survival of these patients with NSCLC. So here I'll stop and thank you again, all of you, for giving me this opportunity. Supreet, thank you again. I really had to revise and learn. I did learn a lot of things like Q30. The Q score is something which I learned when I presented this. Thank you, Supreet.
Thank you, sir. It was really gracious of you for accepting to deliver this talk because I know that it was just a span of 2 to 3 weeks, but a lot of learning points from your talk. And I think I'll have to revise again watching the video to understand some of the concepts that are new to me. But there are a couple of questions that I have. I even invite questions from other speakers and those who are listening to the talk. My first question is, sir, how do you see the role of comprehensive genomic profiling in non-small cell lung cancer today? Do you feel it is relevant at all, or are we stumbling upon unnecessary noise that will just distract us without yielding anything?
Okay. First thing which I told in the first slide itself, that should I look at a very clear 8 to 12 panel for which I have a drug. The point here is, yes, at the diagnosis, we would like to have those mutations or genetic changes that we have a drug to target with. Very clear. But if I'm using, let's say I have a PDL1 high, I did an NGS to rule out any specific like EGFR or ALK, where I wouldn't do a immunotherapy. I'd also like to have in my panel the STK, the KEEP and other things. So what I mean to say is I will try to at least go to a lab which has the 30 gene panel, which is not only targeting the 12, but also keeping into focus the TP53, the STIC, the KEEP, and the others 4-5 which are there, which are very important for me probably to push me or not to push a patient too much for a particular therapy. But bare minimum, I will use those 12 for which I have a drug. But more important that rather than the comprehensive and the hotspot is the depth of the read is very, very important, and coverage will not be important because that's a hotspot panel. But at least we should be looking at the Q score and we should be looking at the depth. These two, if not satisfactorily, I'm not very confident because in rare mutation, you need very deep depths. So this is how I will look at it. But on progression, I'll be more comfortable using a little larger panel because I also want to look at the mutational pathway.
Okay, sir. And the last question from my side is often we get these phone calls from the lab partners who are doing the NGS saying that the tissue is not sufficient. Do you want to proceed with tissue depletion? Should we really be saying okay to that tissue depletion because we understand that tumor content is something that is very important to pick up uncommon alterations? Or we should just offer to do a rebiopsy or send a liquid biopsy instead?
I think the second part is the best part. I think this is just to save their business, if I have to say that. And I told you what the content should be. If it is less than 10%, I would also not send the sample for NGS. I rather do a second biopsy, send the liquid. By the time my second biopsy is getting processed on paraffin, I will see that the liquid biopsy, whether there are enough material for run the liquid biopsy. So this is how we should proceed. The tissue depletion is something that I think is something I'll be very, very skeptical and more skeptical after I've done this talk. I'll be a little more skeptical and we should discourage that because if you're not confident, as I told you, the genetic material, if you're at 30 nanograms, if you're less than that, there's no point going through it. 100 is something that's ideal. So ask them next time, what is the genetic material output? Because we don't ask them counter questions. And next ask them, what is the Q score? So now tell me this, and then I'll tell you whether I want to go for it or not. And what is the base pair fragments which you got? Is it 300 to 500 base pairs? Or are you getting some 50 to 100 base pairs? So you are not going to get your results. I think I will also ask them counter questions from now. So they are also aware, boss, ab to ye log bhi sawal karne lage hain. Let me be prepared and not give them silly options.
Thank you, sir. Thank you so much. This is indeed a huge learning from me, because I have been so far giving green signal to these lab partners left and right whenever they ask for tissue depletion, thinking that it is something that will give me some answer, but this is wrong, is what I learned from your talk today. Thank you, sir. But I request you to stay, if possible, till the end of the session.
Yeah, I will. I'll try to stay.
Next speaker is Dr. Satyajit Pawar, who would be speaking about ROS1, NTRK, and KRAS alterations and management of patients with these alterations. Over to Dr. Satyajit.
Yeah. Hi, good evening, everyone. So, can I share my slide? Yeah. Yes. So, the topic given by Supri is management of ROS, NTRK, and KRAS. What we'll look at is the biology, testing methods, what are current targeted therapies, types, dosing, toxicities, and what can we do in practice. So starting off with ROS1 alterations, around 2% of NSCLCs will have these ROS alterations. But surprisingly, it was first noticed in 1918 breast cancer and glioblastoma cell lines. And the first significance in NSCLC was seen in 2007. Biologically, if you see, these patients are young, non-smokers, female more than male, high incidence of brain mets, almost 40% at diagnosis, with cumulative incidence of almost 80%. There is some literature which says that these tumors have high incidence of pericardial lymphatic mets and also high incidence of DVT. Predominant histology is adenocarcinoma with SNR and solid subtype, but you also can see in lipidic papillary mucinous and other subtypes also. It is also recommended to do ROS1 testing in patients who have mixed tumor histologies as well as squamous tumors without any previous history of smoking. So it's a receptor tyrosine kinase localized to chromosome 6. It's a standard tyrosine kinase receptor which has extracellular domain, transmembrane domain, and a kinase domain. It has a phylogenetic similarity to ALK. So you see the receptor tyrosine, the tyrosine kinase receptors also have a common action on ALK as well as ROS. It is an orphan receptor, and mouse studies have shown that NEL2 can be a binding partner. Now, ROS rearrangement, the partner is important because the different partners will have different downstream pathways and they localize differently in cell. So the most common partner is CD74, which is seen in around 50% of cases, and you have other partners also. Out of these, CD74 is important because it is linked with high incidence of brain metastasis, and it is also linked with differential response to your tyrosine kinase inhibitors. So the detection of ROS1 fusions is by either you can do IHC screening. So the clone which is used was D4F4. This clone has a less sensitivity. So there is another clone called SP384, which has higher sensitivity to detect ROS1 IHC. But this can be false positive. So the false positive rates can be around 10 to 15%. And that's why the IHC is not considered diagnostic as compared to ALK. And you need to confirm it with NGS-based method. The best method is to do combine DNA and RNA-based sequencing. We'll look at why it is important. So coming to ROS1 inhibitors, there are multiple ways by which it can be classified. So structurally, they can be classified as cyclic versus non-cyclic. It is important while understanding resistant mechanisms. You have drugs which can act on specific gatekeeper or solvent-front mutations. Then you have type 1 and type 2 inhibitors. So difference between type 1 and type 2 is type 1 inhibitors, these are reversible competitive inhibitors of ATP. So they bind at ATP binding sites. They only bind in active conformational set. And therefore, if there is a mutation which alters this ATP binding site, then these inhibitors will not work. While type 2 inhibitors bind to ATP as well as there is another hydrophobic pocket behind this. So they have a broad mechanism of action. If you look at the timeline of ROS1 approvals, as we had seen, the ROS1 was discovered in 2007 in lung cancer, but the first drug was approved in 2016. And right now we have multitude of drugs which are approved like crizotinib, entrectinib, repotrectinib, and taletrectinib. The first generation drugs are entrectinib and crizotinib. Other drugs like ceritinib, brigatinib, and lorlatinib also have action on ROS. The median PFS with first generation inhibitors is around 19 to 15 months. If you look at the second generation inhibitors, which are repotrectinib and taletrectinib, the median PFS can go as high as 38 to 45 months. And the third generation inhibitors, that is zidesamtinib, it is currently just under trials for a first line TKI naive space. Important point is crizotinib do not have intracranial activity, while if you look at the third generation inhibitors, their intracranial activity is as high as 80 to 90%. So if you look at the ROS TKI pre-treated space, so right now we have crizotinib and entrectinib available. If the patient has been treated with crizotinib, the action of entrectinib in such patients is actually very less. So the overall response rates are only 11% with median PFS of 4.7%. If you look at lorlatinib data, though the drug is not specifically approved by FDA, it has we have been using this as a ROS1 inhibitor in a pre-treated patient. The data is slightly better. You have response rates within range of 40 to 50% with PFS of around 7 to 8 months. But if you look at the second generation inhibitors like lepotriptanib and taletrectinib, the response median PFS are better, and you also have a better intracranial activity. The third generation inhibitors can be used in patients who have been already exposed to second generation inhibitors also. So if you look at the overall response rate as per prior treatment, post crizotinib, the best activity you can see with second generation inhibitors, while lorlatinib retains some of its activity. Post entrectinib, you have data for second generation inhibitors and third generation. While post second generation, there is only data of using zidesamtinib with response rates of around 40 to 50%. If you look at specifically intracranial activity, we know that crizotinib do not have intracranial activity. Entrectinib is one drug which has around 80% intracranial overall response rate. So if you have patients who had a baseline CNS metastasis, try to prefer entrectinib over crizotinib. Other second generation inhibitors and third generation inhibitors, the intracranial response rates are within tune of 80 to 90%. So currently for a CNS metastasis upfront patient, we have a approval for repotrectinib also. So coming to pharmacology, this one of the important is all of these drugs are subsets for CYP3A4. So you need to keep in mind drug interactions. Out of these, the available drugs are crizotinib. The dose is 250 mg BD with or without food. Entrectinib is around 600 mg OD. And you can see the doses of other drugs also. I would skip these slides in interest of time. Coming to toxicities. The toxicities are dependent on which, so you have a on-target toxicities and you can also have off-target toxicity because of other pathway inhibitions. And some of the toxicities can be peculiar to that drug. So if you look at crizotinib, you have more of a GI toxicity in the form of nausea, vomiting, diarrhea. If you look at entrectinib and repotrectinib, taletrectinib, these are also TRK inhibitors. So you will have a neurological toxicity in the form of dizziness, neuromuscular weakness, dysgeusia. And some of the important toxicities to remember are taletrectinib has a good amount of transaminitis, while zidesamtinib has a good amount of CPK elevation. So if you look at toxicities to watch out, for crizotinib, you have hypophosphatemia and neutropenia. Entrectinib, weight gain. Lorlatinib, we already know the important toxicities. Repotrectinib, dizziness and anemia. And taletrectinib has a transaminitis, QT prolongation. Zidesamtinib is CPK elevation. So these are some of the important toxicities we need to watch out while using these drugs. Now coming to resistant mechanisms, these are by in large, this can be on-target or off-target resistant mechanisms, and off-target can be due to bypass pathway or a histological transformation. So on-target resistance is usually is because of the point mutations, which can alter the binding sites of your TKIs. So for ROS1 TKI, you have two major mutations which can be which are solvent front and gatekeeper mutation. Out of these, the most common is G230R. This is a solvent front mutation, which is seen in almost 40% of patients. So what this mutation does is it basically replaces guanine with a bulky arginine. So you have a large molecule occupying the entry site of the TKI, and it causes a steric hindrance. While similar to and another important mutation is gatekeeper mutation, which is around 10% cases. So basically, it alters the hydrophobicity of that pocket. So you have the alteration in pocket. Therefore, the TKIs cannot bind to that site. There are other mutations like hinge and activation loop site or hydrophobic pocket alterations, which are not that common, and but you can see these mutations in different patients. So how to bypass this mutation? So one of the important mutation is G2032R, which is a steric hindrance mutation which causes steric hindrance. So if you make a structure compact like cyclic structures, then these drugs can go inside that pocket, avoiding the steric hindrance. So this is important to know because your second generation inhibitors have a cyclic structure, so they can act on G230R mutations. Now, if you use drugs in sequence, so if you use first line inhibitors, then followed by second line inhibitors, there can be accumulation of compound mutation. So the common compound mutation which can occur is L2086F. This is a beta sheet mutation. And what it does is basically alters the ATP binding site. So you have a steric hindrance to TKI as well as a binding site mutation. And that's why all type 1 TKI inhibitors cannot act in this type of mutation. So you have to find out a drug which acts at a different site. So that's why type 2 inhibitors can work in this type of complex mutations. So if you look at different type of mutations, solvent front, gatekeeper, hinge and activations loop, and C-terminal loop. All of these mutations cause resistance to first generation, but you have a preserved activity of second generation drugs. And the only important mutation which causes pan type 1 inhibitor resistance is hydrophobic pocket mutation. And you have to use type 2 inhibitors which are crizotinib, glitatinib. So out of these, what we have available is cabozantinib. So that cabozantinib can be used in patients who have failed on first and second generation of TKIs. So if you look at management algorithm for M1 cases, if you have brain metastasis, prefer TKI with higher intracranial activity, that is entrectinib or repotrectinib. If no brain metastasis, you can go ahead with first generation inhibitors like crizotinib. In oligoprogression, you try to do a local therapy and continue your TKI. Similarly, in CNS oligoprogression also, if you have multifocal CNS progression, it's better to switch to TKI with more intracranial activity. For systemic progression, it's better to do a biopsy and look at which type of mutation you have and whether your TKI will work on this gatekeeper or solvent front mutation. If you have those mutations, you can switch to second generation inhibitors. If you have bypass pathway activation, you look at which bypass pathway is activated, and you can combine two TKIs. And if there is histological transformation, the best treatment is to switch to chemotherapy. Now, coming to NTRK, the NTRK alterations are rare. The data from MSKCC database or MD Anderson database is around 2.24%. Chinese data is around higher, so you have around 0.56 to 5.59% incidence in squamous as well as adenocarcinomas as per Chinese data. The most common alterations in NTRK1 and in lung cancer is 1 and 3, while NTRK2 alterations are extremely rare in lung cancers. They can also be found in neuroendocrine and sarcomatoid carcinomas. So you need to push for testing broader NGS panels in these type of lung cancers. They are mutually exclusive other alterations. And there is no strict clinical feature by which we can identify these mutations. So we know that for EGFR AL cross, you have a young female patient, but this is not true with NTRK. So if you look at the NTRK prevalence in lung cancer as per MD Anderson data, it is around 0.24%. The median age is 48, slightly male predominant, nevus proper around 75%, and you have a good number of squamous as well as neuroendocrine carcinomas in this database also. So the NTRK was first discovered in colon cancer in 1982, but the first drug or first approval came in 2018. So you have a long history of NTRK development of NTRK drugs, and right now we have second generation drugs approved in 2021. You have three NTRK receptors, TRK-A, B, C. These receptors activate different downstream pathways. So you have a MAP kinase pathway for A, TRK-B has PI3K, and TRK-C has phospholipase C. And because of this, their toxicities or their biological functions are also different. This is a circus plot of NTRK fusions in CL lung. So if you look at NTRK2, the incidence is very less. One important thing is, if you look at NTRK1, the most common partner is also on the same chromosome. So these are called intrachromosomal inversions, and these can be easily missed on fish. So if you look at testing methods, the gold standard is RNA based. And if you look at, but you have a IHC as a screening method. There are some important points to note. IHC is very sensitive for TRK1 or 2, but it is less sensitive for NTRK3. And there can be background positivity in neuronal and muscular tissue. So this is very commonly seen in patients who have sarcoma and GIST. So if you get an NTRK IHC positive, ideally you should confirm it. Fish, as I told you, intrachromosomal inversions in NTRK1 can be easily missed with breaker point partner because there is no very large breaker point in intrachromosomal inversions, and this can be easily missed on fish. DNA based, if you have a very large intronic area to amplify, this DNA based NGS can miss that, and this can be easily commonly seen in NTRK2 and 3. So that's why RNA based NGS becomes a gold standard. Only drawback of this is liability of RNA. It's the technicality and failure of QC testing in RNA. So you have two first generation TRK inhibitors that are larotrectinib and entrectinib. You have these trials like Scout, Navigate, and Star Trek for entrectinib. The median PFS, these are basket trials, so these are irrespective of their histological subtype. Important thing is larotrectinib has a CNA penetration, but it is a substrate for P-glycoprotein, and that's why their intracranial activity is less as compared to entrectinib. These are second generation inhibitors, salitrectinib, repotrectinib, and taletrectinib. Again, this is histological non-specific data. Important thing to note that TRK, the resistant pattern. So similar to ROS1, TRK also has a solvent front and gatekeeper mutations, which acts similarly to as we have seen in ROS. So these second generation inhibitors have activity on these solvent front and gatekeeper mutations. If you look at lung cancer specific data of these mutations, so you have a larotrectinib, entrectinib, repotrectinib side by side comparison. The dosing is 100 mg BD for larotrectinib, 600 mg OD for entrectinib, and repotrectinib is starting 160 mg OD for 2 weeks, and then you increase to 160 mg BD. Median PFS of around 22 to 28 months in larotrectinib and entrectinib data. Median OS of around 42 months. And for repotrectinib, the data is recent, so you don't have a median PFS yet reached. But if you compare ROS1 data, it is around 35 to 40 months. So we are expecting around that months of PFS in TRK also. Again, similar to we have seen as previously, these are strong substrates for CYP3A4. So you need to have keep drug interaction in check. The taletrectinib should be taken in empty stomach because absorption is pH dependent. So you need to avoid PPI and H2 blockers, and it requires a ECG monitoring. Entrectinib and repotrectinib also cause some hyperglycemia, hyperuricemia. So you need to have check on your uric acid levels. Now the side effects of these drugs are very interesting. If you look at the initial picture, these are all receptors on which entrectinib and larotrectinib is covered. There are multitude of receptors. They have their action. So you will have some off-target adverse events: fatigue, nausea, constipation, diarrhea, transaminitis. All adverse events are because of off-target activity. If you look at the TRK specific adverse event, these are dizziness, paresthesia, ataxia, and dysgeusia, and they are dependent on which TRK these drugs act. So TRK-A is important in paresthesia. TRK-B is for weight gain, dizziness, and withdrawal pain, and while TRK-C is only for dizziness and ataxia. So because of their differential action on this TRK, the side effect percentage is different in all these TRK inhibitors. But if you can remember in short, neurological side effects like paresthesia, dizziness, ataxia are seen in your TRK inhibitors. Coming to resistant mechanisms, again, similar to ROS, you have on-target, off-target, and transformation. On-target is point mutations, off-target is bypass pathway activation. Important to note that the bypass pathway activated in these are usually RAS-RAF kinase and MET amplification. So you have drugs which can be targeted. So you have BRAF inhibitors, you have MET inhibitors which can be targeted, which can use to target this off-target by activation. As I told, the mutation is different, but their action is their final output is similar to ROS mutation. So you have a solvent-front mutation which decreases the drug attachment by steric hindrance. You have a gatekeeper mutation which obstructs the entry of drug, and you have a beta plated mutations like in ROS we have XDFG mutations which directly destabilize binding site. Your type 1 inhibitors cannot act. And similar to ROS, you have type 2 inhibitors is cabozantinib which can act on these DFG mutations. So this is basically a TRK inhibition spectrum. So if you look at the G667 mutation, this is a DFG moiety mutation which causes resistance to type 1 inhibitors, and you have activity of cabozantinib in such patients. Another important thing is patients who NTRK mutations can be acquired as a bypass pathway to your other TKIs like EGFR or MET. So I have seen a patient who was on MET inhibition and had acquired NTRK mutation as a resistant mechanism. And in such patients, you can combine your therapies to give some form of PFS benefit. So these are commonly NTRK1 mutations, and the partner is usually TMP34 or LMNA. And these you can target with combination of your EGFR TKI and NTRK inhibition. Now coming to last part of my talk, that is KRAS mutations. This was a very interesting part for me to read because KRAS mutations initially was considered undruggable. And within last 5 years, you have large number of KRAS inhibitors and understanding of KRAS biology. So we'll look at what has changed in KRAS. So KRAS mutations can be, or KRAS biology can be considered in 3 parts. You have a biologic frontier. So you have a KRAS mutation. These can be allele specific. So you have a KRAS G12 mutations, KRAS non-G12 mutations, and other KRAS mutations. And these can have a different immune microenvironment as well as bypass pathway activation. Secondly, KRAS mutations can be co-mutations with other mutations. So if you have a KRAS P53, it is considered immune hot. KRAS STK LMB, it is immune cold. KELP is very aggressive phenotype, and SMARC and CDNK, which are considered as a marker of poor prognosis. So in KRAS also, you have now different groups which behave differently with your therapies. And then you look at clinical frontier, whether this patient have brain metastasis, whether these patients can tolerate your pan-RAS inhibitors, or you will need a mutation-specific inhibitors, and then you can combine other bypass pathways with KRAS to get better activity. So what happens in wild and mutant state? In wild state, there is constant interplay between KRAS active and KRAS inactive site. So KRAS GDP combination is inactive, while KRAS GTP is active, and there is constant interplay between these two. When you get a mutant KRAS, this balance is shifted to a active conformation, and then there is a downstream signal pathways which are usually our PI3K, AKT, mTOR, then NF-κB pathway, and there is cell proliferation. So we all know that KRAS is a bulky protein, it's a globular protein, so you don't have a well-defined pocket. And in physiological conditions, the binding molecule is GTP, which is extremely small molecule, and you need to have a drug which can compete with this molecule. So that it was very difficult to find a drug which can mimic GTP or GDP and bind that pocket of GTP. And we know that KRAS G12C are most common, but there are around 58% mutations which can be KRAS non-G12C. And these can be G12D, G12V, you have G13 and GQ61 mutations. And this we have previously discussed. In KRAS also, there can be different groups. So KRAS P53, KRAS CDNK, KRAS LKMB. And they respond differently to specifically to immunotherapy agents. So you need to know which co-mutation is there along with KRAS. So coming to KRAS alteration in lung, G12C is most common, 12%, while G12V and D are other mutations. G12C is classically linked with smoking. So if you have a smoker, you will find a G12C. But if there is no history of smoking, the most common alteration found is G12D. And for blocking KRAS, you have different methods. So one of the most common discovered is G12. Why G12 is most common, that we'll again see. So you can block, you can have either mutant-specific KRAS, you can have a pan-KRAS inhibitors, and you can have a pan-RAS inhibitors. So as previously said, I told in physiological state, you have a constant interplay between RAS and RAS active and RAS inactive site. When there is a change from RAS GTP to RAS GDP, so there is a hydrolysis of ATP to GTP to GDP. In that conformational change, there opens a pocket which can be targeted. So this was initially discovered in 2013. They showed that when there is conformational change from active to inactive side, at that brief point, there is an opening of pocket, and this pocket can be targeted with drugs. So after that, we have seen the growth of KRAS inhibitors. Why specific KRAS G12C? So KRAS G12C is supposed to have a highest rate of hydrolysis. So that's why probably G12C, there is a high chance of opening that pocket, and you have a drug which can target that mutation. So coming to G12C inhibitors, these were first tested in 2 phase 3 studies. We have a sotorasib and adagrasib. Adagrasib, the study is Crystal 12, which compares 600 mg of BID compared with docetaxel, and we have a sotorasib 960 mg compared with docetaxel. Both of these trials showed improvement in PFS. So you have PFS of around 5.5 months with adagrasib, and sotorasib it was 5.6 months versus 4.5 months. And based on this, both of these drugs were approved. But if you look at the data for overall survival, the data for adagrasib is not mature, but for sotorasib, the median OS was not different. The primary endpoint of trial was PFS. So based on this, it was approved, but we'll see what has happened to sotorasib in future. The common toxicity of these drugs are gastrointestinal. You have diarrhea, vomiting, nausea, transaminitis, and commonly these we see around discontinuous rates of around 8 to 10% as compared to docetaxel. So if you look at the efficacy, both of these drugs have similar efficacy around 5.5 months of PFS, the grade toxicity rate of around 40 to 50%. The sotorasib story has evolved now. So you have a mature data for OS, and it was not significant. And currently, FDA had denied full approval, and they have requested a full post-marketing studies to see whether this OS or the PFS can replicated in real world. So the currently sotorasib approval is accelerated approval. It is not a full approval in second line setting. Now, what factors will determine how effective your G12C inhibitor is going to act? So as we have seen previously, the activity of G12C inhibitor is dependent on the opening of that pocket while there is hydrolysis between GTP and GDP. If you look at the median reaction time of these reactions, it is around 30 minutes and 9 minutes. In your sotorasib and adagrasib should have minimum reaction time less than that to attach to that pocket which opens between these interactions. And if you look at the sotorasib and adagrasib, their reaction time is higher than these interactions. That's why these drugs are not so potent. They have limited effectivity to outcompete your GDP KRAS interactions. So that's why you are coming to next generation of KRAS inhibitors. And there are multitude of inhibitors. Out of these initial 2 are important, olomorasib and divarasib. If you look at the activity of olomorasib and divarasib, the median PFS for divarasib is almost 13 months. And for olomorasib, it is around 6.5 months. As compared to sotorasib, it was around 5 months. The overall response rates are also better, reaching up to 50 to 60%. As compared to sotorasib, it was around 30%. Now we have talked about G12C, G12D. It is important because these are most common mutations in other type of cancer. So you have colon cancer, pancreatic cancer, where this mutation is predominant. In lung cancer, it is around 4%. And currently you have phase 2 data of zoldonrasib, which has shown around overall response rate around 60%. There are other inhibitors which are currently in clinical trials. Now coming to pan-RAS inhibitors. So it will act on your KRAS, all type of KRAS mutations. It will also act on KRAS, NRAS, and HRAS. The first in human trial is of daraxonrib. So daraxonrib, difficult to pronounce. In lung cancer specifically, the recommended phase 2 dose is 200 mg daily, and there is active current phase 3 trial is recruiting versus docetaxel. If you look at median PFS for this drug is around 9.8 months, which is pretty better as compared to docetaxel, as we can remember. So docetaxel we are around PFS of around 5 to 6 months. Median OS of these patients around 17 months, and we have a phase 3 trial running for this drug. Again, resistant mechanisms as seen in other TKIs, you have a point mutation, then you have amplification, and you have other unknown mechanisms. I will not go into detail of this specifically. Using KRAS inhibitors after progression on first generation inhibitors. So there is data for olomorasib and elironrasib after sotorasib. So median PFS in these drugs are almost 8 and 6 months. So you have some data for sequencing in this in KRAS G12C specifically. Now, as we have seen, if KRAS is activated, you have other bypass pathways, other downstream pathways, which can be MAP and PI3K pathway, and there are parallel interaction between immunotherapy and EGFR pathway. If you look at KRAS inhibition, once you inhibit KRAS, there is reduction in immunosuppressive cells, increase in pro-inflammatory cytokines, increase in activated T cells, which makes basically your tumor hot. So there is large number of research going on combining KRAS inhibitors with immunotherapy. There is phase 2 data shown that you have better responses, but high number of grade 3 toxicities. Specifically, if you look at the data of olomorasib with pembrolizumab in patients who have PDL1 expression more than 50%. So you have a KRAS G12C plus pembrolizumab, and the response rates are reaching as high as 90%, and median PFS is not reached. If you look at the data for single agent pembro in such patients, the median PFS is only 7.7 months. While if you combine it with KRAS inhibitors, it can go as high as up to 30 months. And right now, there are multitude of phase 3 trials running exploiting these combinations. So you have a combination with PDL1 inhibitor and KRAS inhibitor plus minus chemotherapy. Multiple trials combine looking at this interaction between KRAS and immunotherapy. As we have seen, KRAS have other parallel pathways. Second pathway is EGFR inhibitor, and there are multiple trials running in lung cancer. You have already approval of KRAS plus panitumumab in colon cancer in CORE-BIG trial. Other pathways which are under trial are SHP2 as well as aurora kinase inhibitors. Again, these are under clinical trials, but you will see case reports where people who have combined KRAS with aurora inhibitors or KRAS with SHP2 inhibitors, and they have shown good responses. So what I would conclude at the end of my talk is you need to do a good NGS panel at baseline. It should cover your basic mutations. It should have a broad and it should have a good depth of coverage to look at these rare mutations. And I would definitely look at other co-mutations, minimally P53 and other immune mutations which can modify your response to immunotherapy as well as TKIs. And based on this, probably I would take my call which inhibitor to use at first line. At progression, ideally, you should do a broad NGS to look at resistant patterns. It could be, and also look at which type of TKI mutations are there. And then based on this, you can take a decision which second line inhibitor to use. And finally, I think KRAS is becoming more and more interesting, and you will see large number of approvals specifically with immunotherapy in such patients to circumvent the immune modulation by KRAS. Thank you.
Thank you, Dr. Satyajit Pawar, for a very comprehensive talk. A lot of new stuff that I have learned. We are just hoping that we crack the hard nut of KRAS soon enough. And if there are any questions, we can. You please feel free to post it in the chat box. Meanwhile, I invite the next speaker, Dr. Akhil Santosh, to deliver his talk on the next set of alterations which are RET and MET. Over to Dr.
Is my slide visible?
Yes.
Yes.
Yeah, first of all, I would like to thank IAO and Dr. Supreet for giving me the opportunity to present today. And it was wonderful listening to my previous speakers, Dr. Sahu and Dr. Satyajit, especially Dr. Satyajit's extensive session on KRAS, NTRK, and ROS. So I promise to not keep it that long, and I will be discussing mainly on the treatment aspects with regard to RET and MET altered NSCLC. So I will not be focusing too much on the initial diagnostic aspects in epidemiology. So, without further ado, so let me get into the talk. So, just give me 1 second. Yeah, so coming to RET mutated NSCLCs. So, as you all know, RET accounts for around 1 to 2% of all targetable alterations in NSCLC. And of all the RET alterations, the most common ones are the target partners are your KIF5B and CCDC6. So KIF5B accounts for around 75% of all RET alterations, and CCD6 comes a distant second, around 30%, and around 5% are your NCOA4 RET alterations. So we all know from our EGFR, ALK, and ROS that the different set of fusions they may account for different prognosis. For example, EGFR, your exon 18 alterations have a better prognosis compared to your L858R. And if you are comparing your ALK fusions with regards to various variants, your variant 1 and 3, they have a better outcome compared to variant 5. And so, in the same way, so do we have any such data from your RET alteration? So, this was a recent paper which was published in the ESMO Lung Cancer Journal, in which this was a retrospective Chinese study, basically. So, what they have seen is that your non-KIF5B RET fusions, basically your CCD6 and your NCO4, so basically they have a superior PFS compared to your KIF5B alterations. So, yeah. So, does chemotherapy work well in RET mutated NSCLCs? So, we have some data from your ALK mutated tumors, which have shown that they have possess a specific sensitivity to pemetrexed-based chemotherapy. So, similarly, we have data from RET mutated NSCLC also, which shows that these tumors they have significantly lower levels of thymidylase synthase expression. So which makes them explicitly sensitive to pemetrexed-based therapy. Also, they possess altered folate and purine metabolism. So yeah. So on the other side, these tumors are cold tumors. They have minimal to scant infiltration of your CD8 T cells, and they have an immune suppressive microenvironment. So they respond very poorly to upfront immunotherapy. So let's come to the treatment aspects. So initially, before your specific RET inhibitors like selpercatinib and your palzetinib were in place, we used to resort to our multi-kinase inhibitors for treatment of RET mutated NSCLC. So these included our older generation drugs like your cabozantinib and vandetanib and lenvatinib. So let's get into the data regarding these drugs. So all these studies they basically included a small subset of patients, around 30 to 40 patients, single-arm phase 2 studies. So this cabozantinib paper was published in Lancet a few years back, in which they had tested this drug in advanced RET mutated NSCLCs. So basically, they included both upfront naive and pre-treated patients, and so they had seen that cabozantinib had a modest activity, response rates of around 25 to 30%, and the PFS of around 5 to 6 months. And the major setback with such non-selective therapies were the increased incidence of your off-target toxicities. So these were not carried forward into further studies. So similar data with the LURET study, which was done with vandetanib, a PFS of around 6 to 7 months and response rates of around 30 to 40%. But unfortunately, vandetanib is not available in our country. And so coming to the specific RET inhibitors. So first, let's discuss about selpercatinib. So selpercatinib, as you all know, it's a potent oral ATP selective tyrosine kinase inhibitor. It targets both activating and acquired resistant mutations, and the dose is 160 mg BID. And the drug, as of now, it's not available in India, so it's marketed by Eli Lilly. So we are still importing this drug. It costs around 3.5 to 4 lakhs per month. So Eli Lilly has promised to bring the drug by late 2026 to India. And so the initial registration study was our Libretto 001, which I'll be discussing in the subsequent slides. And this drug, like the other TKIs, they are mainly metabolized by the CYP3A4 enzymes, and the drug is available as 40 mg and 80 mg capsules. So I personally have given only the 40 mg capsules. So yeah, so this is just a schematic diagram showing the difference between our non-selective and our selective retin inhibitors. So what are the other indications apart from NSCLC that selpercatinib is approved for? So basically, the Libretto 001 was a basket study and which had included a variety of RET mutated solid tumors. So they have indications in other tumors like your differentiated thyroid cancers, medullary CA thyroid, and any other solid tumor that expresses RET. Post your first line of therapy, you are well within your rights to give selpercatinib. So let's go into the latest update of the Libretto 001. This was the latest 5-year update, which was published in JCO last year. So what they have seen is that the overall response rates were very high. It was around 82.6% in treatment-naive patients and around 60.5% in your pre-treated patients. So I think among the targetable alterations, I think RET inhibitors have one of the highest reported overall response rates. And for treatment-naive patients, the PFS was close to 2 years, and our OS, median OS, as of now, it is not yet reached. And this drug has got a very high intracranial activity and with a reported response rates of close to 85 to 90%. So as you all know, any patient with a RET mutation, they have a chance of developing CNS metastasis to the tune of 60 to 70% during their treatment course. So coming to the most common adverse events, the non-specific adverse events include your dry mouth, diarrhea, fatigue, and the most two classical RET-related side effects are your hypertension and your altered LFTs, your increased ALT and AST levels. And they also have a propensity, like some of the other TKIs, to cause your pseudo increase in your creatinine. So this is a phenomenon that is seen with some other drugs like your breast cancer drugs like your olaparib, abiraterone, etc. So this is due to the MATE transport inhibition, so which can lead to a decreased creatine secretion and your false increase in creatinine. So this is also seen with your selpercatinib. Incidence is very less, mind you. And this is just a continuation of what I was discussing. And serious hepatic adverse events may occur. In fact, it is one of the black box warnings regarding selpercatinib. And QT prolongation is another side effect. And very rarely, life-threatening hemorrhagic events may also occur. Yeah, so this is a very peculiar adverse event, but it is not that rare also. So this is intestinal lymphangiectasia. It is specifically reported with both selpercatinib and pralsetinib. I myself have not seen this adverse event, but I have seen one patient who had developed a chylous pleural effusion with RET inhibitors. So that is also a reported toxicity. So basically, these you might not see them in the initial trials that I had mentioned before, because all those are registrational trials which had reported out very early. So these peculiar side effects like your chylous chylous effusions, and intestinal lymphangiectasis, they are seen with prolonged administration of drugs, and they are also seen in patients who respond well with the drugs. And as you all know, lymphangiogenesis also shares your VEGF dependency. So, as you all know, to some extent, selpercatinib inhibits your VEGF also. So that might be the reason that these side effects are seen with RET inhibitors. And most cases are asymptomatic or wild. Basically, this was a paper, I think, the listeners, they can go to JTO and read this. So this came around 2 weeks back. So it's a beautiful report on how to manage intestinal telangiectasis, and how they are diagnosed. Mainly, they are clinical diagnosis and basically diagnosis of exclusion, and management is basically conservative. So basically, you temporarily halt the drug and you give them a low fat, high protein diet and diuretics on an SOS basis, and most of them resolve on a temporary stoppage of the drug. And you are you can, the guidelines still say that you can rechallenge the drug or switch over to another RET inhibitor. So this is not an indication for for permanent discontinuation of the drug. So coming to the main study, that is the Libretto 431. So this was the main important phase 3 study which had compared selpercatinib versus your chemotherapy. So the study had showed that selpercatinib had a significantly increased median progression-free survival of more than 2 years, 24.8 months, which is more than twice the median PFS that is reported with chemotherapy. Response rates to the tune of around 84% and duration of response of more than 2 years. The OS as of now is immature, so we don't have the final OS results as of yet. So this was reported last year and published and presented in ESMO conference, ESMO World Congress 2025. So coming to neoadjuvant selpercatinib. So this is a new concept that we have already encountered in the EGFR and the ALK space. So in EGFR, we recently have the report of the NeoAdora study in which they had studied neoadjuvant TKI. Basically, it was a 3-arm study where they had taken neoadjuvant chemo or neoadjuvant osimertinib or neoadjuvant osimertinib plus chemotherapy. So they have seen that the arms which contained a TKI, they had a better major pathological and a pathological response. So the same was carried forward here. So this was the Libretto 1 cohort 7 in which they had tested, they are still testing. The final results of this cohort are not yet out. So the world is slowly moving towards the NACT space. And it would be very interesting to see the results of this study. And this is the latest readout, which came in a press release by Eli Lilly last week. So this was the result of Libretto 432. So basically, they had studied selpercatinib in the adjuvant space. So this had a positive DFS. So this is in par with the results of your Adora and Alina in the EGFR and the ALK space. So now we have the third TKI, which has come into the adjuvant space. So coming to the next drug, prazitinib. So like selpercatinib, it is a selective inhibitor. It targets the CCD6 red sites and prevents their fusion with the KIF5B red sites. Also, it has mild inhibitory action on the other kinases like your DDRC1, TRKC, FLT3, JAK, and FGFR. The dose of selpercatinib was 160 BD. For prazitinib, it is an OD dosing, 400 mg OD. The side effects are slightly different. Some of the side effects are common, like your red class side effects, like your hypertension, transaminitis, they are all common. But there are two peculiar side effects with prazitinib. So basically, the patients taking prazitinib have a slightly higher incidence of atypical lung infections, pneumonitis, and they have hematological toxicities, which are not seen commonly with selpercatinib. It's basically in neutropenia and thrombocytopenia. So, prazitinib was studied in the IAIO study, so which was the the counterpart of Libretto 001 for selpercatinib. So this had taken from the recent JCO paper, which had this was the ASCO guidelines for management of targeted mutations in NSCLC. So basically, this was taken from the red section. So here, basically, the FDA had taken serious notice of this increased incidence of atypical lung infections with prazitinib, and they had actually sent a cautionary letter to the health authorities by the sponsor saying this. So this is one aspect that we clinicians have to take into account. So these are the results of ARROW. So basically, again, the response rates were almost similar as that of with selpercatinib, but the median PFS was slightly on the lower side. It was around 16 to 17 months. But it's hard to compare both the studies as the patient population and the trial eligibility criteria was completely different. And so coming to Accelerate. So Accelerate, this was recently presented in the ELCC, which was over 2 weeks back. So Accelerate is the counterpart of your Libretto 431. So Libretto 431 compared selpercatinib versus chemo. So Accelerate compared prazitinib versus your chemo IO. So here, this was a positive study, just like your Libretto 431, sorry. And so the PFS was increased 18.7 versus 9 months. The OS as of now is not yet reached. It's not yet significant. The response rates were significantly increased with prazitinib. So soon we might have an approval for first-line prazitinib. So coming to the resistance mechanism, just like what Satyajit sir alluded to in his talk, so the resistance mechanisms are pretty much the same. So you basically have your solvent front and the gatekeeper mutations, which are the two on-target acquired resistance mechanisms. The most common, the solvent front mutation is your RET G810. And basically this mutation, it reduces the activity and binding of selpercatinib by increasing the steric hindrance. And like other targetable alterations, the off-target mechanisms are pretty much the same. So you have alterations in your KRAS, MET, HER2, and EGFR. And now we have a lot of new compounds which help in overcome this resistance to RET G810, which have a superior intracranial activity. So the final results of all these are not yet out. And so that's it with RET. So I'll quickly move over to the MET alterations in NSCLC. So this is a slide that you all must be well aware of. So the MET alterations in NSCLC are basically divided into your MET exon 14 skipping, MET amplification, and your MET overexpression. So I will be focusing more on MET exon 14 skipping. And so basically your exon 14, it helps in the regulation and stabilization of your MET receptor. So any alteration in this, which can result in your impaired MET ubiquitination, can lead to increased oncogenic MET signaling, and which is the reason for Metexon 14 skipping NSCLC. So this class of mutations accounts for around 2 to 3% of all alterations in NSCLC. And epidemiology wise, this is slightly different from your EGFR and ALK. This is seen in a slightly older population. There is no strong relation with smoking. The studies are mixed. Some report that it is seen both in smokers and non-smokers, and some report that it is seen more in light smokers. So we don't have much, a conclusive data on that. And the incidence is slightly higher in your sarcomatoid tumors compared to your adeno and squamous. And again, this does not have a proper sex predilection also. So this is the ratio is almost 1:1 for Metexon 14 skipping. So now let's come to the molecules, the multi-kinase selective inhibitors, which are approved for your Metexon 14 skipping. So basically, we divide them into type 1, type 2, and type 3. Type 1 is again divided into 1A and 1B. 1A are your older non-selective molecules like your crizotinib and enzatinib. 1B is your newer selective molecules like capmatinib, tepotinib, and savolitinib. Of these, capmatinib and tepotinib are currently available in India. Capmatinib is basically a Novartis molecule. Tepotinib is marketed by Merck. Savolitinib, unfortunately, it is available only in China. And your type 2 inhibitors are your competitive inhibitors, which bind to your inactive conformation. These are your older drugs like cabozantinib. And type 3 are your allosteric binding inhibitors like tivantinib. So I will not be discussing into too much in detail on type 2 and 3. So coming to our main trials for or major molecules. So for crizotinib was studied in the Profile 1001. So this is the oldest study. So this was not per se for Metexon 14 alone. So basically, the study had included all ALK, ROS, RET, and MET. So here the Metexon 14 cohort. So basically, they had a response of around 30% and a PFS of around 7 months with crizotinib. And the downside of crizotinib is again the poor intracranial activity, because Metexon 14 skipping mutations, they have a tendency of around 50% during the course of illness to have a CNS spread. So that is one downside with crizotinib that we cannot address. And coming to our other drugs, capmatinib was studied in the Geometry Mono 1, and Vision was studied, tepotinib was studied in the Vision study. So if you can see that the activity of these two drugs is somewhat similar, and they have more responses and a better PFS if you give it in the first line compared to line 2 or later. And the PFS is around 1 year. So if you compare that with your RET inhibitors, they are slightly inferior. So RET inhibitors in first line have a PFS of more than 2 years. So uh, so again, so does the MET gene expression have a role in response? So this was a study which had assessed the same. So they found that all the responders in the geometry model and the vision study, they went retrospectively and they checked for the MET expression. And so they had seen that the patients who had a better MET expression were the ones who had responded well. So coming to toxicities of special interest. So as you all know, MET inhibition invariably causes edema. So peripheral edema is one of the most common side effects with MET inhibitors. And the other one, as I told you before, the increased pseudo elevation of creatinine. So that is also seen with your MET inhibitors. And other rarest and peripheral edema in turn can result in hypoalbuminemia. And rarely they can be transaminitis. ILD and pleural effusion are very rare side effects. And coming to the resistance mechanisms, I will not be going too much into detail. This is quite similar to the other approved targeted therapies. You have on-target and off-target mechanisms. Off-target mechanisms are currently the same as that of that I had already previously mentioned. And there are newer molecules which have not yet come to the market, which are known to target these on-target mutations. So again, another important question is, does your immunotherapy work? So if you get a So if your patient does not have access to capmatinib, tepotinib, or savolitinib, so are you justified in starting these patients on upfront chemoimmunotherapy? So this is a very important question that we face in our clinics. So we have data with BRAF and KRAS that these are tumors that are associated with smoking signatures. They have a good infiltration of your T cells, and they are highly immune activated tumors. You can get away with immunotherapy in the front line. You need not resort to targeted therapy. So do we have some data similar to that for your Metexon 14? So let's see. So Metexon 14, they have a high TMB. They are mainly seen in smokers. They have they also have a high PDL1. But again, if you see the data for Metexon 14 compared with the other classical targetable alterations, the response of IO is not that great. So it might be better compared to your EGFR and ALK, but far inferior when compared to your KRAS, BRAF, and your HER2. So is there any data which compared basically chemo IO versus MET inhibitors as first line? So this was basically a retrospective study. This was published in CCR. So here they found that patients with the highest expression of PDL1 to the tune of around 70%, 80% or more. So these patients, they had a better PFS, that is a PFS1, when you start them off with a chemo IO instead of capmatinib or tepotinib. On the other side, patients with a PDL1 of less than 50%, they fared well when you start off with a targeted therapy upfront. But again, this is not a prospective study, and I don't know how much we can deduce from this for our routine clinical use. But again, but as of now, I use this data while dealing with Metexon 14 skipping. So I take a look at the PDL1 before I start them on therapy. So again, our famous molecule amivantamab. So does this have any role in Metexon 14 skipping? So this is one part I wanted to make clear. So there was a specific cohort of the Chrysalis study which specifically tested amivantamab in Metexon 14 skipping mutations. So this actually had some significant activities similar to your capmatinib and tepotinib. The ORRs and PFS was slightly on the lower side. It was around 5 to 6 months, but the response rates were around 50 to 60% when you treat them upfront with amivantamab. So again, if you don't have access to TKIs, you may resort to first-line amivantamab for Metexon 14 skipping. So again, this is the last part. So now we had discussed Metexon 14. Now let's move to meta amplification. So meta amplification, again, it can occur in two situations: your upfront meta amplifications and your meta amplification that occurs after the therapeutic pressure after you give EGFR inhibitors. Basically, they are seen in EGFR inhibitors on after progression on third generation EGFR inhibitors. So I would be discussing more on that aspect. And meta amplification, again, there are two methods to detect. Your FISH is your go-to method, the gold standard. It is widely used and available. So, why does it have an advantage over NGS? Because basically you can detect all sorts of abnormalities. Basically, your focal amplifications, your polysomies, and your duplications. The false negatives are less with FISH compared to your NGS. NGS is not yet standardized for the same, and there is no morphological correlation if you use a DNA NGS. So, at least for now, we resort to FISH specifically when you are planning to employ a MET inhibitor therapy in EGFR mutated lung cancers later on. So coming to a few studies, so INSIGHT 2. So INSIGHT 2 basically was a study which was conducted specifically for patients who had an EGFR mutation and who had progressed post a third generation EGFR inhibitor like osimertinib. So here they had taken basically patients who had a MET gene amplification more than 5, the copy number more than 5 on a solid tumor NGS, or if you're doing a liquid biopsy, a plasma copy number of more than 2.3. So in such patients, basically they had tested the addition of tepotinib with the continuation of osimertinib. And so they had seen that this strategy produced, fair enough responses to tune of around 50% and a PFS of around 5 to 6 months. And they had seen that the responses were more in patients who had a gene copy number of more than 10. So coming to Savannah, so Savannah had a similar design. So in Savannah, they used, this was a Chinese study, and they had taken patients who had progressed post osimertinib, and they had continued osimertinib along with addition of savolitinib. So here, what they have seen is that they had basically stratified into different levels of IHC expression and your FISH on the meta amplification copy numbers. So they had seen that patients who had an IHC expression of more than 90% and a copy number of more than 10. So basically your middle column. So they had the highest responses and the greatest PFS. So actually your response is actually a metric which is related to your gene copy number and your IHC expression. And so the Sachi is the only, so the previous two studies that I discussed were all phase 2 studies, small patient numbers. So Sachi is the only phase 3 data that we have right now. So Sachi was recently presented in last year's ESMO Congress. So again, this is a phase 3 study which compared post progression on osimertinib, Savlo plus osimertinib versus your chemotherapy. So again, this had a beautiful design. So basically, they had taken patients who had progressed post an earlier generation of TKS. They had to have only a copy number of more than 5, and post progression on osimertinib, they included patients with a MET copy number of more than 10. So here they found that giving a combination of Savlo plus Osi had a PFS of around 8.2 months versus your 4.5 months in chemotherapy alone. So yeah, again, so the question is that we, at least in our clinics, so for post progression on osimertinib, we usually tend to either go ahead with a ABCP sort of a regimen, or we tend to go for Mariposa 2. So the Mariposa 2 was positive for PFS, and it had a trend towards OS also. But did they actually test for MET? So the Mariposa 2 was actually for all comers. So they did not specifically test for MET alterations in this. So do we actually have any data for amivantamab in this space which had shown some relation with MET expression? So this was actually seen in the Chrysalis 2 study. So in the Chrysalis 2, there were two cohorts. So basically, the cohort E and the cohort F. So basically, those two cohorts, they had taken post-progression osimertinib patients, and they had seen the data of amivantamab monotherapy and combination with lazertinib. So here they had prospectively tested for MET amplification and IHC expression. And here they had shown that the response rates were higher for patients who had a high MET IHC expression compared to a low expression. So this is something which we can employ in our clinics. So I think, yeah, this is the last slide. So recently, so right now I had discussed our employing NGS and our fish, and now we have something for IHC overexpression also. So for MET IHC overexpression, recently we have a molecule called, this is an ADC, the telisotuzumab vedotin. So this was basically for EGFR wild type tumors. So till now I had discussed EGFR mutated tumors. So this is EGFR wild tumors who are progressing with an increased MET IHC expression. So here they had taken the cutoff of 50%. So here, this ADC had a response of around 40% and a PFS of around 4.5 months. So but as of now, this is not yet FDA approved. So I think, yeah, so that is my last slide. So yeah, thank you once again.
Thanks, Dr. Akhil. Again, this was a very comprehensive talk, a lot of information. I just have a couple of questions. One is to the point that you have said, the MET expression in patients who have exon 14 skipping mutation will kind of predict the responses to MET inhibitors. So does that go on to suggest that we should be looking for MET expression as well in those who have MET exon 14 skipping mutations?
I would not do that in clinics because that is a small retrospective data that we have from geometry studies. So we don't yet have prospective validation as of now. So there are a lot of reasons for false elevation of, there can be many reasons for MET increased expression without having a proper increased copy number. So the reasons for false positivity are very high. So I would not yet employ the same in our clinics.
And second question is, you have mentioned that fish is more reliable for MET amplification. For example, if a patient's NGS also shows that there is amplification of MET, should we be retesting it with fish to confirm, or it is good enough if the patient has done an RNA-based NGS?
As of now, we don't have data for that. Confirming it with fish, because fish was the older technique that was actually employed. So all the studies, they have not done NGS in isolation. So they have done both NGS and fish together. So all the studies that I had mentioned before, Insight, Sachi, Savannah, they had done either NGS and IHC together or NGS and fish together. So there was not a study which tested only NGS. So as of now, I don't think there is a need to retest with fish if you're using an RNA-based NGS.
Right. And my last question is just a general question. How effective have you found all these Chinese TKIs to be, if you have personally used any of these in your clinical experience? because we have a swathe of drugs that have been coming up, aumolertinib or savolitinib, some other tongue twisters that are coming up. So are they really good? How much can we rely on the data that is being produced?
So TKS, I don't think anything is available as of now in our country because avlotinib is available only in China. We don't have access to it. Omlotinib is being launched by Glenmark later this year. We don't have omlotinib as of now. Immunotherapies, I've used a lot of Chinese drugs, but TKIs, not much experience as of now.
Okay.
Yes.
Thank you so much, Dr. Akhil. For the last part of the session, I'll be talking on HER2 positive, HER2 mutant, as well as HER2 overexpressing non-small cell lung cancer. I have skipped the BRAF part because of the want of time, and I'll be sharing my screen to the audience. Just give me a second. Yeah. So first of all, I should thank IAIO organization for giving us this wonderful platform and the technical support to conduct some of these academically enriching sessions with some of the wonderful speakers who are academically inclined and are willing to spare some time from their busy schedules to be able to be participating in these sessions and spread the knowledge. That is the precise aim of this session. And without wasting much time, I'll be talking about HER2 alterations in non-small cell lung cancer. If you see broadly, I will be keeping my talk very crisp, as Dr. Akhil Santosh did, to the point. So there are broadly three HER2 alteration types that we see in non-small cell lung cancer. The commonest is HER2 gene mutation, which is seen in about 4% of the patients, and that is the targetable HER2 alteration. And second targetable HER2 alteration is, of course, the HER2 protein overexpression. HER2 protein overexpression, which is seen in about 2 to 38% of the patients. So the data is variable. As of today, we don't have anything to target HER2 gene amplification. The data is also variable. There is no discordance. There is no concordance between HER2 gene amplification to overexpression to HER2 gene mutation, and that we'll be learning subsequently. And while looking at the NGS report, you should remember that HER2 gene mutation is not reported as HER2, it is reported as ERBB2 gene mutation. And it is detected by NGS or RT-PCR. We all know that NGS has become the most popular method to perform molecular testing in non-small cell lung cancer space. HER2 overexpression, as expected, we do it by means of IHC. Now, these are the HER2 mutations possible. The commonest mutations are seen in the tyrosine kinase domain, in which we have exon 20 insertions to be the commonest, and then we have exon 19, exon 21 to be the other second and third common mutations to be seen. While in extracellular domain, we have S310F mutation, which is seen about 15% of the patients. Now, when I say that exon 20 insertion mutation is found in HER2 gene, it means that there is an insertion of 4 amino acids between 775 and 776, which are YBMA. So this is the commonest or classical exon 20 insertion mutation that is seen in HER2 mutant non-small cell lung cancer. Then you have other insertions such as AYBM. Then you have A771, M774 duplication, which can also be found in exon 20 insertions. And of course, there are other exons that might be involved in the tyrosine kinase domain mutations. So these are the broad categories that I was alluding to. Commonest are in the tyrosine kinase domain mutations, and next commonest are extracellular domain mutations. Coming to HER2 overexpression, it is scored in the same manner as that of breast cancer. 0 is no staining or incomplete or faint or barely perceptible membrane staining in tumor cells less than or equal to 10%, and any staining more than 10%, any staining in more than 10% of the tumor cells is considered to be HER2 1 plus 2 plus 3 plus according to the intensity of their stain. This is HER2 gene amplification, which is defined as HER2 is to CEP17 ratio more than or equal to 2. These are the HER2 targeting drugs that have been studied so far in non-small cell lung cancer, but we have approvals only for 2 drugs. One is TDXT, which is an antibody drug conjugate, and the other is a TKI, which is zongertinib. There have been various EGFR TKIs which have been repurposed to target HER2, but none of those drugs could give us promising responses. And with the arrival of zongertinib and TDXT, we are finally seeing a decent survival benefits in these patients. Now, a typical phenotype of a patient with HER2 mutated adenocarcinoma is the fact that these patients would be mostly female. They would be never smokers or light smokers, and it presents usually in 50s to 60s of the patient's age. Then histopathology, most common is adenocarcinoma, but we do tend to see them in mixed histologies such as adenosquamous carcinomas or carcinosarcomas, but it is never found in pure squamous cell carcinomas. As I said, the commonest is exon 20 in-frame insertion of YVMA. It is generally mutually exclusive, but probably we'll be seeing more and more data of HER2 exon 20 insertions in combination with other genetic alterations as well, with increasing advent of NGS testing, as it is the case with EGFR ALK or ALK, EGFR ROS, etc. Clinical presentation, as it is the case for any other genetic alteration, the most common stage at presentation is stage 4. It has got high propensity of brain metastasis. At least 30 to 40% of the patients who have HER2 genetic mutation will develop brain metastasis either at baseline or during the course of their treatment. Now, if you look at the first-line chemotherapy, remember, we don't have approvals yet for HER2-targeted therapies in first-line space, but soon we will be getting a TKI. But as of today, the first-line chemotherapy plus immunotherapy would be the standard of care. This is one of the large retrospective studies that looked at the response rates to pemetrexed platinum combination, and it showed a median PFS of 5 months in these patients, which goes on to say that these patients are poor responders to chemotherapy alone. Then we have some data for efficacy of immunotherapy in these patients. Some of it was already presented by Dr. Akhil. We can see that the chemoimmunotherapy has shown some marginal improvement in the survival, but not so great. There was no sustained immunotherapy benefit in these patients, and there is always a need for some better precision medicine in this space. These are the various historical HER2 targeted therapies. As I was saying, a lot of EGFR targeting agents were repurposed. Some of the drugs, HER2 targeting TKIs, were that have been used in breast cancer were repurposed, but uniformly we could see that the response rates have been very poor, either single or in double-digit numbers within 20%. Only promising drug that showed decent responses was TDM1, but again we found discordant reports in different trials. There was one trial which showed response rates of 0%, and there was another basket study which showed response rates to the tune of 50%. We are not sure whether TDM1 is really helping the patients with HER2 mutation. Now, as I said, TDXT was the first drug to show some promising durable responses in HER2 mutant non-small cell lung cancer. We all know that it is an antibody drug conjugate with a cytotoxic payload of SL38, and it is a topoisomerase 1 inhibitor with a drug to antibody ratio of about 8. And the mechanism of action is it binds to HER2 extracellular domain of HER2 receptor, and then it is internalized by means of endocytosis, and inside the cell the cytotoxic payload is released. It goes and binds to the DNA and inhibits the topoisomerase 1, causing cytotoxicity. It also has got bystander effect, wherein the drug diffuses into the extracellular space and goes into the adjacent cells which are not expressing HER2, and again inflicting cytotoxic damage to those cells. And there is antibody-dependent cell-mediated cytotoxicity as well by this drug. Now, this was the first trial which showed benefit with the TDXT in HER2 mutant non-small cell lung cancer. In this, there were 2 cohorts. The first one was cohort 2 with patients with HER2 mutations. And there was cohort 1 and 1A, which looked into its role in HER2 overexpression. This is now we'll be talking about cohort 2 outcomes. And if you see, the trial population included HER2, the kinase domain mutation was the commonest in the study population. extracellular domain mutations were there, but it was in single digits. We cannot we won't be able to draw conclusions from that particular subset. And if you see another important aspect, CNS metastasis was seen at baseline in about 36% of the patients. As we can see in the waterfall plot, there were a large number of patients who responded to TDXT. And this was the point that I was alluding to earlier. There is a huge discordance between HER2 mutation expression and amplification. For example, if you see some of the patients with HER2 expression of 3 plus or 2 plus did not have any amplification at all, and a vast majority of patients with HER2 mutation had zero expression of HER2. So we cannot use these testing methods as well as these alterations interchangeably to decide our treatment. And this was the response. These were the response rates. The confirmed objective responses were seen in about 50% of the patients. And the progression-free survival, remember, these were the patients who have already progressed on first-line chemo plus or minus immunotherapy. And we are seeing a PFS, median PFS of about 8 months, and overall survival was about 17.8 months. And as expected, we see GI toxicities mainly with TDXT, but most importantly, grade 5 toxicities were seen in about 13 patients, which is something very significant in a total population of 91 patients. And this probably has happened because of the dosing strategy that was used in this particular trial, 6.4 mg per kg body weight. The reason why they had to do another trial to confirm the dose or dose equivalence of a lower dose of 5.4 mg per kg that I would be discussing subsequently. But most important point that we all look into in any TDXT trial is the frequency of drug-induced interstitial lung disease, and that was seen in about grade 2 to grade 5 toxicities were seen in about 24% of the patients, which is very significant. Almost 1/4 of your patients who receive a dose of 6.4 mg per kg would be experiencing drug-induced ILD if you are deploying this particular dosing strategy. Now, as I said, there is a huge discordance between HER2 expression and mutation. Therefore, we cannot rely on HER2 expression to determine whether there is HER2 mutation or not. Then comes Destiny Lung 02. As I was saying, at least 1/4 of patients who receive 6.4 mg per kg dose could go on to develop a clinically significant interstitial lung disease. Therefore, this was a trial. This cannot be called a trial. It was a study that compared. It was a randomized study that compared 5.4 mg per kg versus 6.4 mg per kg, and found that the response rates were equivalent, and even the PFS and OS rates were exactly the same. And this is not a direct comparison. The reason why we will not have p-values, it is only showing that a lower dose is as good as or as efficacious as 6.4 mg per kg at the cost of much lesser toxicities. If you see grade 2 to grade 5 drug-induced ILD, it was seen in about 10% of the patients as opposed to 25% that we saw with 6.4 mg per kg. Even if you see the patient-reported outcomes, the quality of life was well preserved in patients with 5.4 mg per kg as opposed to 6.4 mg per kg. So this kind of established the standard dose of TDXT as 5.4 mg per kg, even in non-small cell lung cancer, as it is the case with other malignancies as well. Now, these were the outcomes in cohort 1 and 1A, which included the patients with HER2 overexpression. Again, if you see, most of the patients had HER2 2 plus FISH positive, and around 20% of the patients had HER2 3 plus status. Around 30% of the patients had baseline CNS metastasis. More importantly, the role of HER2 overexpression is something that we tend to ignore in patients with EGFR and KRAS mutations. A significant number of patients were included in this particular study, and the outcomes are pretty interesting that I would be presenting in the next slide. But if you see in the overall cohort, the response rates were to the tune of 30% in both 6.4 mg per kg and 5.4 mg per kg. They had to split another cohort to 1A because by then 5.4 mg per kg has established its efficacy without by reducing the toxicities significantly in non-small cell lung cancer. If you see this waterfall plot as it is understandable, we can see a vast majority of patients who are showing at least partial response or a stable disease. But if you see the patients with EGFR and KRAS mutation as well, these patients were also showing responses upon receiving TDXT. And this goes on to say that we are supposed to test TDXT overexpression, HER2 by IHC as well, so that we will be able to offer TDXT to these patients if at all there is an overexpression. And again, it is the same thing with cohort 1A as well. So if you see the median PFS, it was more or less the same in both the dosing strategies. Even overall survival was more or less the same. Now, what about the patients with brain metastasis? We remember in both Destiny Lung 01 and 02, there was no intracranial responses that were looked into. They had done a separate secondary analysis, and it was found that in patients who received local therapy for brain metastasis versus those who did not receive local therapy for brain metastasis, the responses were same, which means TDXT is efficacious regardless of the patient receiving palliative radiation to the brain metastasis. It was to the tune of 50% in patients who received 5.4 mg per kg dosing. This again is the waterfall plot showing good responses. Now we all know the practical aspects of TDXT. Just to quickly summarize, we need to dilute it in 5% dextrose. It is available as a lyophilized powder, which has to be reconstituted in sterile water and then diluted in 100 ml 5% dextrose. Initial administration is over 90 minutes, and subsequent administrations can be done over 30 minutes if the patient did not have any significant infusion reactions. And remember, both the dilution fluid bottle as well as the infusion set should be covered by a black paper so as to protect the infusion from the light, and it should be through a codon set. And the dose adjustments are 5.4. First dose reduction is 4.4 mg per kg. Second dose reduction is to 3.2 mg per kg. And beyond that, we are not supposed to continue the drug. And most important point is, if any patient is developing grade 2 or more ILD, the drug has to be discontinued permanently. And we know how to manage ILD. It is with steroids, initially starting with 1 mg per kg body weight and later on tapering depending on the responses. And even if a patient had one grade 1 toxicity, if the patient is requiring more than 28 days for the ILD to completely subside, we are not supposed to continue the drug subsequently. Now, these are the resistance pathways to TDXT in NSCLC. It is very interesting to see. The most common resistance is because of the resistance to payload. You have SLF11 gene loss, which codes for helicase enzyme, and if that is lost, the expression, the sensitivity to cytotoxic payload in TDXT is also lost, and therefore you have to deploy an alternative payload to manage this particular resistance, which we are still seeing a lot of newer ADCs with newer payloads that are coming up as the years pass by. Then there are other resistant mechanisms such as ABCC1 copy number gain or amplification, which results in overexpression of drug efflux pumps that results in loss of cytotoxic payload from the cell into the extracellular space. And you have HER2 domain IV mutations or truncation of extracellular domain of HER2 and loss of HER2 in totality that are seen even in breast cancer as well. Then comes the game changer drug in HER2 mutant non-small cell lung cancer, which is zongertinib. It is a game changer because of its high efficacy and very low toxicities. This was the trial that established the role of zongertinib in patients with HER2 tyrosine kinase domain mutations. We are seeing the response rates to the tune of 70%, 71%. Again, remember, these were the patients who have already received first-line therapy, and this is in second line that we are seeing this kind of responses. And again, the waterfall plot is so beautiful to see that a vast majority of patients are benefiting from this particular drug. The median PFS is around 12.4 months, and it was seen regardless of the type of HER2 mutation, but I would not read much into the subgroup analysis because the most common mutation, as it is the case in the TDXT trial as well, was HER2 exon 20 insertion, YVMA insertion. If you see the drug-related adverse events, there were very few, as opposed to what we used to see with the EGFR TKIs or other HER2 TKIs that were used priorly in HER2 mutant non-small cell lung cancer. There were only 4 patients who developed grade 3, grade 4 drug-related adverse events, and regardless of the dose, and it is said that even the dose escalation till 360 did not yield any. Did not result in any serious adverse events, but the final dose that was decided to be the standard was 120 milligrams as per this particular trial, and that is the standard dosing strategy that is used. These were the objective response rates. As I said, we are seeing disease control rates to the tune of 81% and objective response rates to the tune of 41%. And there were other 2 cohorts which looked into patients with non-tyrosine kinase domain mutations, which was kind of disappointing because the responses were barely 30%. And in patients who received prior antibody drug conjugate targeting HER2, be it TDM1 or TDXT, again, the disease control rates were exceptional to the tune of 97%. Therefore, we can use zongertinib in a patient who has already been exposed to TDXT in the second line after having progressed on first-line chemoimmunotherapy. Now, this is the game-changing result that we have seen. Cohort 2 included patients who were treatment naive, and you can see that the overall response rates were about 77%, which is the highest that we have seen so far in HER2 mutant non-small cell lung cancer. There are various toxicities, but again, these are not very severe. Grade 3 toxicities you can see barely in single-digit number of patients, and 6-month median PFS was 79%. And this encouraged the trialists to go ahead and recruit patients for BEAMION Lung 2, which is a confirmatory phase 3 trial of zongertinib in first-line HER2 mutant non-small cell lung cancer. Coming to the practical aspects of administration, as I said, the dose is 120 milligrams once daily. First dose reduction is 60 milligrams, and there is no second dose reduction beyond that. Most common toxicities are GI and hepatotoxicity, as it is the case with any HER2 targeting TKI. Rarely we do see dermatologic, cardio, and drug-induced ILD, but these are very, very rare. More or less, it is by and large, it is a well-tolerated drug. As it was already discussed by Dr. Satyajit Pawar, we should be very cautious about the drug interactions with all these TKIs, especially with the CYP3A inducers or inhibitors, to modify our dosing strategies accordingly. And BCRP substrates are again not encouraged to be used along with zongertinib. So to summarize, if you find a HER2 mutant advanced non-small cell lung cancer, the first-line treatment still remains chemoimmunotherapy. Second-line treatment, if you have given TDXT, the third line would be zongertinib, and vice versa if the patient has received other way around. Sorry for the disrupted slide, but to conclude, the only targetable HER2 genetic alterations are the mutations and overexpressions. As of today, we don't have any data for HER2 amplification. It only confers poor prognosis to the patient and poor responses to other therapies, but there is no role for any HER2 targeted therapy in just amplification. And TDXT dosing is 5.4 mg per kg, not 6.4 mg per kg. And we have zongertinib finally coming as a game-changing TKI in HER2 positive space as well in non-small cell lung cancer. And the approval, we should remember, for zongertinib is only in patients with tyrosine kinase domain mutations. We are still yet to have drugs that are that can be used in patients with extracellular domain mutations. With this, I thank everybody for patient listening, and also the wonderful speakers that took part in this particular session. Over to the IAIO team for further proceedings. Thank you so much.
Thank you, sir. If there is any question from the audience, please put there in the chat box.
Okay.
Sumrit, can you hear me?
Yeah.
Nice talk, Supreet. I just wanted to make a small comment. So, so like you mentioned, basically there are three alterations in HER2. Basically, your TKD domain mutations, your juxtamembrane, and your ECD, extracellular domain mutations. So, there was recently a paper in JTO which came that, which concluded that basically the response to immunotherapy might not be that great for your TKD mutations, which account for the majority, but your ECD mutations still respond well to IO. So basically, they still have a tumor inflamed microenvironment with a good infiltration of T cells. And for those mutations, your response to your zongertinib and sevabertinib are to the tune of only 25 to 30%. But they have a good PFS when you start them off with chemo plus IO. So this is one small comment I wanted to make.
Okay,
So
okay. Thank you.
this goes for both
Yeah,
ECD and JMD, juxtamembrane also. But for your conventional TKD mutations, your first line should anyways be your TKIs only.
yeah, yeah. Thank you. Thanks for that point, Dr. Atul.
Sir, can we conclude?
Yeah, please, please. Thank you
Yes.
so much.
Okay, before we conclude, I would like to thank on behalf of IAIO Expert Insights to our faculties for sharing their expertise so generously, and a big thank you to our audience for your time and engagement. A special note of gratitude once again to Dr. R.N. Supreet for his leadership and a program director. All the participants will be receiving their certificate within 2 to 3 working days to a registered mail ID. I repeat, all the participants will be receiving their certificate within 2 to 3 working days to your registered mail ID. Thank you so much. Thank you. Good night.
Good night.
Good night, sir. Thank you.